Awareness Month, September. It's also National Newborn Screening Awareness Month, and those two causes are uniquely entwined because our families are impacted by newborn screening because of the new sickle cell being on the newborn screening panel. So this is kind of a celebration in a town hall, and our topic is pretty serious, but we want to make sure that everyone is getting on line. I do have some housekeeping. So please chat your name, your city, your state. I'm sorry, my name is Andrea Matthews, and I'm the founder of the Children's Sickle Cell Foundation. Almost forgot to say that. But as I was saying, please chat your name and your city and state in the chat box. And then if you would like to share one way that you had fun this summer, even though we were social distancing, just to have a little bit of fun with that. So thank you all for being here. Just a little housekeeping here. All of the lines will be on mute throughout the presentation until we get to the question and answer segment. If you're going to chat a question into the chat box, we ask that you, if it's to a particular speaker, identify them by name by saying either Dr. Gladwin, Dr. Bogan, or Dr. DeCastro. And please, we want you to use the camera feature. If you would not mind putting your cameras on so that we can see your lovely faces while we're doing this. But please, if you have to move around, please try not to do so without taking your camera off so that you're not distracting others. And then to just enjoy yourself. This is going to be a nice learning experience, and this is all about you. This is all about getting information and using the information to keep ourselves safe and to protect those that we love. I am, even though I started by saying I'm the founder of the Children's Sickle Cell Foundation, I am a mom of a almost adult with living with sickle cell disease, and that we are among family and friends, and we're meeting others who are working in this, and we're really excited to have everyone on board. So those are the housekeeping items that I have. And I just wanted to take a pause, and before we introduce the speaker panel, I just want to take a moment to acknowledge and remember those who have lost their battle with sickle cell disease worldwide. So just going to take a moment. Okay. Next we have, we're just going to meet our speakers, and I'm just going to go through a little bit of their bio, and our first speaker, and they're going to be in order of the way that the bios are and their pictures. So Dr. Lord M. DeCastro is an associate professor of medicine and clinical chief of benign hematology of the Hematology Oncology Division at the University of Pittsburgh Medical Center. Before joining UPMC, she directed the Duke University Sickle Cell Center. During her clinical career, she has provided acute and longitudinal care to patients with sickle cell disease and other benign blood disorders. As a clinician, she works on addressing and managing acute chronic sickle cell disease complications, chronic pain, preventative medicine, and psychosocial support. She has been involved in more than 30 NIH, National Institute of Health, and pharmacy-supported clinical research as principal investigator or site co-PI, including designing studies and managing the regulatory, data-related, research-related clinical activities, resulting in outstanding enrollment and rapid completion of studies. She is co-author of more than 45 manuscripts covering the areas of psychosocial issues, pulmonary hypertension, the use of social media and mobile technology for health-related outcomes, drug development, and pregnancy outcomes in females with sickle cell disease. Dr. Laura DeCastro. Dr. Deborah L. Bogan is the director of the Allegheny County Health Department. Since assuming her leadership role, she and her team have stayed on top of the pandemic and provided consistent, measured, and common sense information to the public while working closely with other stakeholders in the county. Prior to her appointment, Dr. Bogan was a member of the Pittsburgh Region Medical and Research Community for more than 2 decades. She held a primary academic appointment as professor of pediatrics at the University of Pittsburgh and secondary appointments in psychiatry and clinical and translational science. For the past 3 years, she served as vice chair of education for the Department of Pediatrics at UPMC Children's Hospital of Pittsburgh. Talking of her own background, Dr. Bogan said at the March 4th press conference, "I bring to this position a fairly wide lens, but am open to eager to expand that lens to more fully understand and address the health needs of our community. My lens includes years of experience providing direct clinical care to diverse families, but mostly families impacted by economic and racial disadvantage. I bring the lens of a community advocate, particularly as an advocate for issues of maternal and child health. I also bring the lens of a scientist, committed to making policies based on the best evidence available." She concluded, "I also look forward to working closely with other county agencies, healthcare organizations, community organizations, and anyone committed to working to advance the mission of the health department, to protect, promote, and preserve the health and well-being of all Allegheny County residents, particularly the most vulnerable." Dr. Bogan earned her medical degree from the University of Colorado School of Medicine and completed both her pediatric residency and general academic pediatrics fellowship at Johns Hopkins Hospital. She is one of the founders of the Mid-Atlantic Mothers Milk Bank and serves as the organization's volunteer medical director. She and her family have lived in Regent Square neighborhood of the city of Pittsburgh since moving here over 2 decades ago. Deborah L. Bogan, Dr. Bogan. Mark Gladwin received his MD from the University of Miami's honors program in medical education in 1991. After completing his internship and chief residency at the Oregon Health Sciences University in Portland, Oregon, he joined the National Institutes of Health in 1995 as a critical care fellow in the clinical center. After completion of a clinical fellowship in pulmonary medicine at the University of Washington in Seattle, he returned for a research fellowship at the critical care medicine department. He later served as the chief of the pulmonary and vascular medicine branch within the National Heart, Lung, and Blood Institute at the NIH. In August of 2008, Dr. Gladwin became chief of the Pulmonary Allergy and Critical Care Medicine Division at the University of Pittsburgh School of Medicine and founding director of the newly formed Vascular Medicine Institute. In March 2015, he became chair of the Department of Medicine at Pitt. Dr. Gladwin is a highly funded basic, translational, and clinical researcher and is principal investigator of a UG3, PO1, and 2 RO1s, and a T32 award, a Burroughs Wellcome Training Award. He is conducting a multi-center clinical trial of riociguat, sorry, I know I was going to mess that up, to treat patients with sickle cell disease and pulmonary hypertension, and has served as PI on the multi-center clinical trials Walk Fast, Pulmonary Hypertension and Sickle Sildenafil Therapy Trial, and de novo, delivery of nitrous oxide for vaso-occlusive pain crisis and sickle cell disease. His new SCD CARE clinical trial will evaluate whether monthly red blood cell transfusions can improve symptoms and prevent hospitalization and death in patients with sickle cell disease. So as you can see, that's Dr. Gladwin, and this is a very distinguished panel. We are so blessed to have you, and we're excited to hear from each of you. So this is how this is going to work. If everyone can put their cameras on, we are going to move right into the presentations with Dr. DeCastro and follow through all 3 presentations, and then we'll go into the Q&A. So thank you all for being here. Dr. DeCastro, I'll stop sharing and you can share.
Sorry, I was mute. Good afternoon. Thank you. This is a pleasure to present today a little bit of data regarding the experience of sickle cell patients and COVID-19. The outline of my talk, I'm going to discuss data from the registry for sickle cell patients that was created here in the United States and now cover patients from all around the world. I will mention the UPMC experience on cases of COVID and treatment for them, and then highlight some points about prevention and treatment of COVID in sickle cell disease. I will start with two case reports. This is a publication for a couple of months ago. These cases are patients with diagnosed with sickle cell disease, but presented with no typical symptom of COVID. The first one is a female, 24 years old, that presented to the emergency room with right chest pain, had normal vital signs, no fever, good oxygen saturation, and the chest X-ray showed some mild infiltrates in bilaterally in the lungs. She was treated initially with antibiotics, and because of her presentation and the findings in the lung, she had a nose swab and throat swab for COVID-19, or the name for the virus SARS-CoV-2, and this test was negative, and she was discharged a day after on oral antibiotics. Next day, she presented again, now with a temperature, with worsening infiltrating the chest X-ray, and at this time, the sputum sample was significant for being positive for the SARS-CoV-2. She was treated with antibiotics, did well, has her pain management with morphine PCA, and was discharged home on stable conditions after 3 days. The second case is this of a male, young male, with sickle beta zero thalassemia on long-term treatment with hydroxyurea. He was admitted because of complaint of left hip pain. He had history of avascular necrosis, AVN, and they noticed that he also had some fluid in the location of the hip pain. He had a temperature that developed on day 5 of admission, and at that time the chest X-ray was fine, but the hip showed worsening fluid that was aspirated and was negative for any infection. Because of the persistent of fever, he was treated with antibiotics and was cultured and evaluated widely for different viruses such as influenza, RSV, and other bacteria. And all of that was negative. On day 10 of this person admission, he developed a new cough and low oxygen down to 82, which improved with some oxygen therapy, but also was noticed to have evidence of hemolysis with decrease of the hemoglobin, increase of the LDH, and was also found by the chest X-ray that have multifocal opacities consistent with pneumonia, and was treated as a early acute chest with a transfusion of 1 unit of red cell. On then 11, the SARS-CoV-2 test was done, and it was positive because he had new chest pain and required oxygen. The decision was to do exchange transfusion with the goal of all our exchange transfusion to decrease the sickle hemoglobin from high levels to at least less than 30%, and this was appropriately done. 2 days later, his oxygenation improved, his chest pain resolved, and because he was persistently febrile, he was enrolled in a clinical trial for treatment of COVID pneumonia. He responded well to that and was discharged home approximately on day 16 after admission on stable condition. So these two cases highlight what has been found on the registry. This registry, as I mentioned before, was initiated at the Medical College of Wisconsin in March of this year. And even though initially was included cases from the United States, now the 300 plus cases that have been included in the registry include cases from Canada, South America, Europe, and Africa. And this is a public website, so anybody that is interested in looking at this data can look at this website and access that data. So data from last week, which is the last update of this registry, showed that 307 patients were reported with an average age of 24, but as you see here, approximately 15 cases were children, I'm sorry, 35 cases were children. The majority of the cases were young adults to age 24, and there were cases reported at age all the way to almost 70 years old. Most of the cases reported were in female, but almost the same amount of male and female. And as expected with sickle cell disease, most of the patients report Black African American ethnicity, but there were some patients that were Hispanic, Asian, and white. In regard with the type of sickle cell disease that was reported in this registry, most of the patients, again as expected, were hemoglobin SS, as you know is the most frequent phenotype and the most severe one. But approximately 20% were hemoglobin SC, and then there were a small number of patients with the other frequent, less frequent genotypes, such as sickle beta 0 thalassemia, sickle beta plus thalassemia, etc. In regard with the patient symptoms in the prior 3 years to enrollment to this registry, what they noticed is that even though there were reports of patients having priapism, male with priapism, acute chest syndrome, 30%, most of the patients, as expected also, 65% or more reported hospitalization due to pain in the last 3 years. And the average hospitalization was 8 hospitalizations within those 3 years with a standard deviation of around 8. Some patients, significant number of patients presented to DD with emergency room with pain, but approximately 8 times in those 3 years, but they were released. And the average of acute chest syndrome within those 3 years on those 30% of patients that have acute chest syndrome was 2 acute chest syndrome. Of note too is that when asked what medication the patients were treated in the past, as expected, a majority of the patients were on hydroxyurea, since that is a standard of care of sickle cell patients, and have been demonstrated that they not only decrease the frequency and the intensity of pain episode, but that also hydroxyurea treatment impact very positively morbidity and decreased mortality in individuals treated with sickle cell with hydroxyurea. Interestingly enough, even though crizanlizumab, also known as Adavio, voxelotor, also known as Obrita, and L-glutamine, which are 3 new sickle cell disease modifying therapy just approved within the last 2 years. They already there were a significant number of patients that were treated also with that, which is very positive to know that the new disease modifying drugs have been already implemented in a significant number of our patient population. In regard with the symptoms that the patient had when they were having after diagnosed with the COVID-19 infection, as expected, more of the patients presented with pain. Some of them had, at least 30% of them had pneumonia, but it's interesting that some of them have heart irregular beat or arrhythmias, pulmonary hypertension, renal disease, and stroke. I'm sorry. The pain was present in a small number of patients, while others have pain and pneumonia. Of interest is that 8 patients developed renal failure during this infection with COVID, to the point that they require, at least 5 of them require dialysis, and 4 of them still have not completely have their kidney function recover after this renal damage. In regard with the treatment that they receive, a lot of them receive blood thinner medication, heparin, either as a prevention, most of them, but also for treatment of clots. Significant number receive azithromycin, and others have received some of the therapy that you have heard and that you will hear more from Dr. Gladwin, that has proven to be effective for treatment of COVID-19, such as corticosteroid, lopinavir, remdesivir, and plasma concentrates. Lastly, this column on your side show what happened with these patients when they presented with COVID-19. Interestingly enough, and very positive, 77% or more were came through evaluation through the emergency room, and only 61%, or not only, but 61%, not all of them needed to be hospitalized. The reality is that within those that needed to be hospitalized, 10% end up being admitted to the intensive care unit, and 5% require mechanical ventilation or intubation. The average time that the patient remained in the hospital was around 8 days. And those that received transfusion, around a third of those that had COVID received transfusion, so around 100. Some of them received exchange transfusion, and the rest received simple transfusions. In regard with the severity of the disease, even though the majority of the cases were considered mild because the patient either were treated at home or did not have any complication, sadly, there was approximately 18% of patients that had the disease complication that was considered severe or critical. Most of the patients that had the disease had resolution of the symptoms, but some of them still we don't know the resolution. And a 5% of the patients succumb. So 16 out of 307 died for COVID-related complications. This slide just highlights our experience at UPMC. To my knowledge, out of 130 patients that had either presented to the emergency room or hospitalized due to painful episodes since March of this year, 33 of them has been tested for COVID-19, and 6 of them have been found positive for COVID-19. One of them had been found positive twice, 72 days in between, and with a negative test in between. Out of those 6 patients, 4 of them are females, 3 are males. The average age is 39 years, but out of those 6 patients, 3 of them were very young, younger than 27, consistent with the average age on the registry, but 2 of the patients that were infected with COVID were more than 60 years old, one of them a resident of a nursing home. In regard with the type of sickle cell disease that this patient had, again, half of them had the most frequent one, hemoglobin SS, but 2 of them were SC, and one of them had one of the more rare genotype, hemoglobin SOR. From those 6 patients, they have been doing well. They have not been severe complications, prolonged hospitalization, or death. Only really 2 of them were hospitalized at any point. The rest of them have, 3 of them were hospitalized. The rest of them really were diagnosed or treated as an outpatient. This last slide is just to highlight that the key things are prevention from the use of masks, physical distance, and hygiene, to continuation, and it's very important to continue current treatment. Those patients that are treated with hydroxyurea, that are on chronic transfusion, that have pain management, it's important to continue with the current treatment to optimize their well-being, and also to follow up with doctor visits. Here at UPMC, we are making an effort to do telemedicine, so visit by phone and by video, to make sure that if patients live far or they are not comfortable leaving their home environment, we can at least still address not only their medical issues, but also any psychosocial issues or community-based issues such as difficulty with acquiring food, etc. So we are here for the patients. They just really are only a call away or a video conference away. Lastly, it's important to early evaluate and treat the symptoms associated with sickle cell disease to prevent complications such as COVID, acute chest syndrome, and other complications. Once the patients are diagnosed with COVID-19, the recommendation is even before diagnosed, but they are sick, admit patients that have acute chest syndrome, worsening oxygen demand, uncontrolled pain, and be treated with aggressive IV pain management, antibiotics, oxygen, etc. We also recommend aggressive therapy for all sickle cell patients with COVID-19 symptoms in regard with transfusion and the COVID-related treatment. And as always, consideration for enrolling these patients in clinical trials that will help advance their care and educate the clinicians, researchers, and other community about ways to treat these patients appropriately. This last paragraph, and I can make it available to the Children's Sickle Cell Foundation, is some resources that are available for clinicians, but also for patients and their support system in regard with how to take care of themselves and others during this COVID-19 pandemic. My take-home message are that these COVID-19 infections are prevalent in patients with sickle cell disease. Patients living with sickle cell disease should make any effort to prevent the disease and to receive aggressive evaluation and therapy. And that sadly, the morbidity associated with COVID-19 in sickle cell disease, although appears mild to moderate in most of the cases, is disproportionately high as compared with other races, given the group of patients that this disease affect. I thank you for your attention, and we'll be ready to question whenever the question and answer part starts.
Well, thank you so much. I did put the resources in the chat box, so whenever you guys have a chance to look over there, and we're collecting those questions for you. And Dr. Bogan, would you like to present?
Sorry, I was not able to unmute myself. Sorry about that. So thank you so much for having me. Sorry for that very long introduction. So I'm just going to hop right in because I was told I have 10 minutes. So I'm going to look real quick at my phone and make sure I stay on time so there's time for question and answers. So I was asked to talk about sickle cell disease and health disparities. So I'm going to just jump right in. The goals today in my 10 minutes are to talk about health equity challenges with COVID-19 in our county and how these are compounded by chronic illness like sickle cell disease. What you should know about case investigation and contact tracing process here in the county and how to avoid scams, and what can families do to protect themselves, their families, and their community. So I hope I can address those three issues during this presentation. So I just wanted to point out that the County Health Department publishes data and updates this dashboard every single day. So you all in the community can see what's happening. This is a graph from the front page of our dashboard that shows our cases by date and our deaths by date. I want to point out that the scales on those two are different. The scales for deaths is just 0 to 8 per day, where the cases by date is in up to 100. So please don't think that they're actually the same numbers. But what you can see is that we had a small surge early in March. We got really quiet here in the county, and at the end of the June, we sort of went crazy, had lots of cases, and it's been coming down steadily since. And you can also see from this diagram that the deaths seem to sort of delay by about 2 to 3 weeks after the cases. The red, yellow, green lines are the Pennsylvania governor's plan for reopening. And then the June 30th line, red line, is where I made the public order to stop public drinking, essentially, to try to reduce the spread. This is also from our dashboard, and this is rates per 100,000 residents by age, gender, and race. In the top left-hand corner, it's for tests. So the orange line is Black females, the red line is Black males, and the other two are white females and white males. And what this graphs show you for tests cases, hospitalizations, and deaths is that we see a significant health disparity in all of our metrics. So what's good is we are testing the Black community at a higher rate than the white community, but we're doing that because they have more cases, more hospitalizations, and more deaths. Our COVID dashboard, I put the link here, is available to you. I do want to say that just the other day, we added a whole extra couple of pages about racial and ethnic disparities on our webpage for you to review. And we've also made the data files publicly available with a collaboration with the Western Pennsylvania Regional Data Alliance. I know there are lots of people out there who would like to actually play with data. Some people do, so that's where it is. These are some pictures from our disparity dashboard. And this is a graph that shows the cumulative case rates by race. And again, orange is Black, Asian is blue, gray is other, and the green is white. And what it shows you is that the rate of cases over time in 100,000 people by race. So it's corrected to the proportion of the population. And I think this slide and the next three all are going to look very similar, that we have more cases by rate of their presence in our community of COVID-19 among the Black community. I'm just going to skip some of these because you can look up these. They're all available. They all show about the same thing, more hospitalizations. And so those data are there and they're alarming, and we should all be concerned. And because sickle cell disease affects primarily our Black population, this is really important for you to understand. So why the disparities? So I like this term, acute on chronic. So this term refers to the longstanding medical condition exacerbated by an acute illness. So often leading to worse outcomes than would have resulted from just the acute illness alone. So if you get an acute illness on top of your chronic illness, the outcome's often worse. And COVID-19 is this novel disease that sort of unmasked a very longstanding underlying health disparity in our community and truthfully across our country. We know that there are underlying health conditions in communities of color, that they have higher rates of diabetes, obesity, hypertension, kidney disease. All of these chronic conditions are associated with worse outcomes for COVID-19. Why the higher rates of chronic conditions? Well, that's a long-standing results of systemic racism and our challenges that we have culturally in our community. The social structure issues that are impacting COVID-19 really are that you're more likely to work as an essential worker outside the home. And again, if you're less likely to be able to stay home and protect yourself, you're more likely to be exposed to COVID-19. So if you work in childcare, long-term care facilities, if you're a grocery worker, et cetera, you're more likely to take public transportation. You're more likely to live in multi-generational homes. And we know that in general, children who experience this infection don't experience it nearly as badly in terms of the outcomes as adults. And as you age, when you get 60, 70, 80, 90, when you get this infection, it's much worse. And so for all those reasons, there are differences in outcome. And so we have to address not just COVID-19, but all those structural issues that exist in our community to really address this disparity. So let me just check my time. So I wanted to just spend a couple of minutes describing what the health department does when we find out that there's a case of COVID-19. So the way this works is somebody gets tested for COVID-19, and the laboratories in our health system report those results. There are certain reportable diseases that come to the health department through our Pennsylvania NEDS, the National Electronic Disease Surveillance System. And so the labs directly report that data into the system, and we as the county health department get notified if you live here in Allegheny County. And that triggers somebody from our health department called a case investigator to reach out to that person whose test is positive. And we call you and we say, hey, we're calling from the Allegheny County Health Department. We're calling about your COVID results. And we're going to ask a lot of questions. We're going to ask about when your symptom onset started. Are there any special circumstances where you work? If you're in the hospital, if you're live in long-term care, if you're a healthcare worker, your race. We also ask about sexual orientation. We ask about whether you've been to large gatherings. We ask about travel. And most importantly, we ask you about who you've been in contact with. We also provide guidance and issue what's called an isolation letter. Our isolation guidance talks about when you can go back to work, what you should do if your symptoms worsen, what are warning signs. We help link people to services who need them. We identify psychosocial needs, and we actually link to services if you need them. So for instance, if you have housing, we put people in hotels when they can't safely isolate and there are high-risk people in the home. We get food delivered and do all those things. So that's what our case investigators do. And they enter the list of contacts that they identify, and they identify something called close contacts, which I'll explain in a minute. They identify the contacts and create a list, and then another team of people who don't know anything about the case call the close contacts. And we have kept those two pieces of information separate because we're not allowed to tell the contacts who potentially exposed them. So we keep those lists separate, and we have separate teams of people who do those calls. So the contact tracers, that's what you've heard a lot about in the news, actually are the people who call the close contacts. And a close contact is defined by the CDC as people who are within 6 feet for at least 15 minutes of a case while the case was symptomatic or 48 hours before that. And that is regardless of whether you were wearing a mask. And case contacts are assigned to our contact tracing team for follow-up. Those case contact tracers will call you, they inform you of the exposure and educate on quarantine and follow your symptoms. They provide information on testing and how to get tested. And we do ask that close contacts get tested. For the contacts, we also ask you to stay home and not go out. So we also do a psychosocial and physical needs assessment and see if there's any way we can help you with services. And we coordinate all those services with our Department of Human Services, our 211 and United Way colleagues, and healthcare providers. And we ask that you will enroll in our contact tracing software, which allows us to send you either a phone call, a text, or an email every day to see how you're doing. If you then suddenly report symptoms, when we call you, if you're symptomatic, we'll go through what you do. But if you have no symptoms, that tracing allows us to do it. It also sends you a notice of when you can go back out into the world and not be quarantined. I want to point out that we at the health department will never ask you for a social security number. We will never ask you for a credit card. We will never ask you anything about money. So if anybody calls you, there's been some scams going on nationwide of people saying, I'm calling from the health department and I want to ask you some questions, and they sound really real, but then they ask you for financial information. If they do, please hang up and call your local police, okay? Do not give we will never ask that information. Either our case investigators or our contact tracers. For any reason, the health department will never ask for financial information. I want to make that really clear. And I also wanted to just mention the difference between isolation and quarantine, because I know those words get used all the time, but isolation separates sick people with a contagious disease from people who are not sick. So if you are a case, you're a confirmed case, you are on isolation, we will send you a legally binding enforceable letter that says you are to stay home for the duration of your illness, and we'll go through what that is. Quarantine separates and restricts movement of people who were exposed to the contagious disease to see if they become sick. And so our contacts of confirmed cases are on quarantine. The contacts in quarantine may or may not have symptoms, and if they do, they become what's called a probable case, and then they flip into our case investigation team. So what can you do as families? We know this virus primarily, at least we believe the virus spreads primarily through droplets. That's through talking and breathing hard and just breathing normally if you're close. We all sort of spray and create droplets in the air. Aerosolized is when those droplets are fine enough that they sort of linger in the air and stay there a while. And we know measles, for example, is a very good aerosolized virus. And then we think that there may be some aerosolization, particularly indoors where the air movement isn't good, and that there may be some fomite, and that's when the droplets land on a surface and the virus stays there and you touch them and you bring them to your nose or mouth. But we think the primary method of spread is droplet, and so the precautions that we talk about is really to Be outdoors as much as you can. Limit higher risk is definitely indoors. Although I will point out, we've had almost no, since we put universal masking and all that, there's been very little spread in our hospital systems, which is all indoors, correct? So people are indoor all day and we're not seeing spread in our hospitals. So that tells me we can prevent spread if we're careful. So strategies to prevent spread are based on that information. So proper mask wearing protects you from droplets, but it also prevents you mostly from giving it to other people. Don't forget, 40% of people with this infection don't even know they have it because they have no symptoms. Hand washing is important to address fomite spread, and physical distancing really helps with all of those. So my recommendations are to stay home, but stay connected. If you do need to go out, wear your mask, do all the things that we've been publicly messaging. Please get your flu vaccine this year. And there is a COVID vaccine, are definitely going to become available sometime in the next couple months to the next year. I hope you will all get that because we don't want you to get COVID-19 on top of sickle cell disease. So in summary, COVID-19 really affects all of us differently, but disproportionately impacts communities of color. The data that we get really informs our response with the goal to reduce spread to high-risk individuals, which are people who are older, people who have chronic illness, and also to decrease that disparity in who gets it. So if you're contacted by the Allegheny County Health Department, please work with us. Your information is safe and protected, and your participation will help us limit the spread. And I hope you all take care of yourself and your families, and I would be happy after the final presentation to answer any questions. Thank you. I will stop sharing so you can.
Thank you so much. Dr. Gladwin. Dr. Gladwin, are you with us? I saw you somewhere here. Okay. Well, while he's...
I think you have to unmute him. We can't unmute ourselves for some reason, Andrea. I don't know. And you can remute me. I'll remute me.
Okay.
There you go.
Okay.
You had me muted.
I'm so sorry. Everyone is muted. I thought we gave everyone the ability to unmute, but thank you. Two excellent presentations. Dr. Gladwin, you're on.
Do you want to have me present now, or would you rather have people ask Dr. Bogan, Dr. Castro questions, whatever you'd like?
Okay, well, go ahead and present, and then we'll get some questions at the end.
So how many people on this have sickle cell disease? You know everybody on this on here, Andrea?
I don't know everyone, but I see quite a few people that I know. So if you want to put your cameras on and raise your hand, that would be great. Or you can raise your hand using the little reaction. There's a little reaction. See, I can shake. See
Does
how
everybody have cameras? I see people waving.
You see people waving? Okay.
Right. So, all right. How many of you are afraid of getting COVID? I'm curious, how many of you get a flu vaccine every year? Wow, that's pretty good. Okay, well, Dr. DeCastro talked about what we're seeing nationally with patients with sickle cell getting COVID-19. And then she talked a little bit about our experience here. And Dr. Bogan has done an incredible job in the Department of Public Health trying to increase testing and public health measures to protect people. I thought it would be interesting to share with you a little bit what's going on in Allegheny County at UPMC and what's going on with the development of a vaccine, because you're probably hearing a lot in the news about a vaccine coming. And so I thought I would share some information about the vaccine and talk about the new science that's coming around vaccines. one of the things to say up front is that everyone's worried that people that are particularly at risk, as you heard from Dr. Bogan, African Americans, Latinos, that they may be more afraid of getting the vaccine. And as you know, there's been a lot of anti-vax things going out. And we know that there's a lot of social media from Russia or wherever that's trying to really disrupt our country. And there's been a lot of anti-vaccination social media. And so I just want to let you know that everyone's worried that the people that may need vaccines the most, which are going to be, again, as Dr. Bogan mentioned, African Americans, Latinos, people that are going to be more likely doing essential work, or more likely living in houses with multi-generational houses, people with more comorbidities like sickle cell or diabetes, that this is a group that needs vaccines more than ever. The second thing we're very worried about is that we may get hit with a 1-2 hook punch, and that is the flu season and worsening COVID-19. Because in the fall, when it gets cold, everybody comes indoors, people are closer together, and it's more likely to transmit. And so we're really worried about a double whammy, and then people maybe not coming into the clinic to get their flu shots because they don't want to be exposed to other people. So we strongly recommend that even now, start looking into your options to getting the flu shot. Wear your mask, get the flu shot. I don't know if Dr. DeCastro, if we can unmute her and see when are we going to be starting flu shots. I don't know if you know that, Dr. DeCastro, when we're going to be starting them in the clinics.
So we usually start the last week of September. I already started to ask. I asked yesterday and we still don't have it. But as soon as we have it, in fact, we will inform the foundation and other sources to make sure that everybody knows that it's available and comfort to get it.
Yeah.
And I also just put a plug. So the county health department will also have flu starting in about 2 weeks. And also that there have been some changes to coverage so that anybody can get it under the 317 system now. So they've lifted a lot of limitations. And so you can get a free vaccine if you're not insured, all kinds of stuff. So I'm happy to answer questions about that. This year is going to be anyone can get it. We're going to get lots of flu out there for people, flu vaccine out there.
And let me warn you that this year, less people in general may get the flu shot because they don't want to go to the doctor because they don't want to get COVID. So we're already seeing childhood vaccines in general dropping. So the worst thing that happens is that we have a bad flu outbreak because of that. And then there's a double trouble with the flu and COVID-19. And we have no idea what they do together. And we have no idea what happens if you were to catch the flu and COVID-19 and have sickle cell. So try to protect yourself by getting that flu vaccine. Now, I have to say we're hopeful that maybe, we've never had a situation where everyone's wearing masks. Maybe we're going to be pleasantly surprised that there'll be less flu this year because of the mask, but we really don't know. So what I thought I would do you all want to hear about the vaccine efforts, this warp speed and what's going on? All right, I'm going to show you some science, but I'm going to try to simplify it a little bit. And I'll just go quickly through some of this. Does everybody see what I'm showing you here? Okay, so first of all, this figure looks a lot like what Dr. Bogan showed you. This is the number of patients in UPMC hospitals. This is at Mercy, McKeesport, Shadyside, Presby, McGee, even in Harrisburg area and Pinnacle. But as you can see, we had this first surge in the spring, and we've just come out of a second surge this summer. And we don't know now whether we're going to hit another bounce here. We do know all the Pittsburgh students are back in college. There's a lot of young people out and about, so we're a little worried. But we just came out of this second big surge. And this just shows the different areas, but in the blue here this is Allegheny County. And what you see is this last surge was mostly in Allegheny County, where that first surge was in Allegheny County, but also in Pinnacle in central Pennsylvania around Harrisburg. So we had this surge right here in Allegheny County. And there's this thing here shows this surge, and it shows people under 60 in blue and over 60 in red. And it just points out that we had a lot of young people that got it in the last surge, and then they give it to the older people. And of course, the older people have more severe infection, and about equal between men and women. But this is very important. And again, Dr. Bogan touched on this. This shows this is Black and non-Black patients. This is just UPMC. And you can see about 30% of our patients that were hospitalized at UPMC hospitals with COVID-19 were African American. And so it just shows again that Black Americans are at higher risk of having a more severe infection that requires hospitalization. And so we think it's even more important than ever that you all think about prevention, masking, trying to get a vaccine when it's ready. Now, one thing I'll point out is the masks are really working, because why did this peak drop? You know, why did this surge go down? And I'm seeing people outside, people are out and about, but the reason this peak probably went down is, one, Dr. Bogan shut down all the bars, right? I think that was probably a big thing, that we just can't be indoors together. But also everybody started wearing masks and got serious about masks. And there's more and more data that the masking really works. The other argument that the masking works is I go to work almost every day at UPMC, and our hospitals are filled now. Our clinics are filled, our operating rooms are filled, the hospital's filled, and we're not having any infections in the hospital. People aren't catching it in the hospital. And the reason is when you go to the hospital, everybody has a mask, everybody stays 6 feet apart, everybody's washing their hands. So all of that seems to be working. So I just want to encourage everybody to wear your mask, try to stay 6 feet apart, wash your hands. It seems to really work. So what about the vaccine? So first of all, we're very proud here in Pittsburgh because Jonas Salk, the polio vaccine was developed here in Pittsburgh. It was rolled out in the city of Pittsburgh, and it was really a major disease that was cured with vaccination. And here you see the polio shots starting in schools. In fact, if you go to the Heinz Cathedral and you go inside, there's actually one of the stained glass just showing a kid getting a vaccine here. You see that? That's the stained glass inside Heinz Cathedral. Andrea, can everybody hear me pretty good? Okay. Now, where did this virus come from? And I'll just remind you that the disease COVID-19, that's coronavirus 2019, the virus is called SARS-CoV-2. So the virus SARS-CoV-2 causes the disease COVID-19. But it turns out that these viruses come from animals, and this virus originally is thought to come from bats that were being eaten sort of as bushmeat, or people were exposed to them in China. But look at this, there's many, many different viruses that can come, what we call zoonotic, that they come from animals. And you can see many of them, like MERS, the Middle Eastern respiratory virus, the SARS-CoV-2, SARS-1, Ebola. There's many of these different viruses. So one thing I think one of the positive things about COVID-19 is we're starting to figure out how to accelerate the development of vaccines. That we need to figure out a way that when we next have a SARS coming out of China, even before it gets here, we're developing vaccines. So there's a lot of science now going in to develop vaccines quickly. So this is an artist rendering of the SARS-CoV-2 virus. So that's the SARS coronavirus 2 that causes COVID-19. And it has these spikes on the front of it, and these are called spike proteins. And these spike proteins are very important because they bind to your cells in your airway epithelium, and that's how the virus gets inside of your cells. And this spike protein, all of the vaccines are trying to get your immune system to make antibodies that bind to and block this spike protein. Everybody wants to hit this spike protein. So the way it works is your body makes these things called antibodies. You probably remember antibodies from school. And the antibodies bind to the spike protein and they block it. So now the virus can't get into your cells. The other thing the antibodies do is they tell your white blood cells to go in and gobble up and eat that virus. So how is a vaccine made? Well, one thing is there's all these steps of safety. So I want to make the case to you that when these vaccines come out, they're going to be very safe. You don't need to worry about these anti-vaxxers. And so what happens? First of all, you develop a vaccine. And these are studies we do in cell culture, in test tubes. Then we treat animal models. We vaccinate animals. And for example, right here at Pitt, we have guinea pigs that get SARS-CoV-2 infection. We have ferrets that get it. And we have non-human primates called macaques. They're little green monkeys. And those 3 animals get this human disease. And so we're vaccinating all of them right now as we speak. And all of the vaccines I'm going to tell you about have already gone through testing in these kind of species of animals. Then you go to something called phase 1. Phase 1 is safety. You give normal volunteers the vaccine and you see whether it's safe and whether they generate antibodies. Then you go to phase 2 where hundreds of people get it, sometimes thousands. And then you go to phase 3, and then you may go to phase 4 after it's licensed. Now, normally, these phases for a vaccine take about 10 to 12 years, if you can believe that. But right now, what's happening is we're going really, really fast. So right now, in only the last 8 months, there's been a ton of vaccines that have been developed. Every little example here is a different vaccine that's been developed and tested on animals. There's about 17 that are in phase 1 that went through safety. I think now it's already up to almost 7 that are in phase 2, but we have 2 of them here in Pittsburgh. And so you can see how many vaccines are being developed for SARS-CoV-2. There are also different types of vaccines, and I'm only going to briefly touch on that for those of you who really like science. But look at this. This was just in the Washington Post. 170 vaccines have been in animal studies. 15 vaccines have already gone into humans for safety. 3 vaccines are in phase 2, meaning does it work? And 7 vaccines are already in phase 3, which is a big study. For example, the Moderna study and the Janssen, the J&J study, those are in 30,000 people each. None of them have been approved, but we're anticipating approval sometime between November to December. And by the way, normally this takes, as I said, 10 to 12 years for a vaccine to go through these stages. What's happening now that there's this effort to rapidly move things forward, and this whole process has been accelerated by about 7 to 12 months. Now, very importantly, and I'm going to mention this over and over, even though this is happening fast, not one step is being missed. Every vaccine we're talking about is going through animals, phase 1, phase 2, and phase 3. There's no step being missed. What's happening that's unique now is everybody's overlapping and working at the same time. So for example, right now, the government is making glass vials. Corning is making millions of glass vials, and companies are setting up their production lines, even though they don't even have the vaccine yet. So the idea is as soon as the vaccine works, we'll be able to produce 100 million vaccines. Now, the way a vaccine works is that normally a virus with those spike proteins binds to your cell and it injects inside your cell a little piece of RNA. And RNA, as you probably know, gets turned into DNA, which get turned into proteins. And it makes new copies of virus. And so now you make new viruses. And then your antibodies on top of your immune cells, called B cells, recognize the protein. And your whole immune system gets activated. And then you make a lot of antibodies, so that the next time you see that virus, those antibodies bind to it and block it. So this is what happens when you catch SARS-CoV-2, you get COVID-19, and you develop immunity. So what we're going to do with the vaccine is we're going to try to imitate this, but without actually catching the virus. So one way is you could inactivate the virus, and this is how the polio, we gave people weak polio, and it goes in, it stimulates your immune system, and you develop antibodies. There's a new way of making a virus, and this is being done by a company called Moderna. They're not going to put the weak virus in. They're actually going to inject a little piece of RNA itself. It's called an RNA virus. And then your body makes the spike protein, and then your antibodies are developed to attack the spike protein. And it's a whole new way of making a vaccine. There's something else called a vectored virus, where you have a kind of like a fake virus. In this case, it's an adenovirus. It's not the normal virus that is the SARS virus. It's like a fake virus, but it's not an infectious virus. That virus goes in, and it also has the spike protein, and your immune system develops against the spike protein. Anyway, so two vaccines have started testing in Pittsburgh. One is from Moderna, this company Moderna, and you've probably heard about this in the newspapers. And this is a unique, it's a new type of vaccine. It's just a little piece of RNA, and it encodes the spike protein. So the RNA, once you inject it into your shoulder, your body reads the RNA and makes the spike protein. But the spike protein can't do anything because it doesn't have a virus. It just sits there, and your immune system recognizes it, attacks it, and you develop antibodies. The second vaccine that's starting in Pittsburgh, I think next month, is J&J. And this is an adenovirus, which is like a fake virus. And it also has RNA inside of it that makes the spike protein. And you're going to then develop antibodies to the spike protein. Now, I'm telling you about these viruses, these vaccines, because both of them have already been through human safety studies. So here's the clinical trials. Again, this just shows you normally all these steps take 2 to 10 years. Everything's been done now in the last, within this last year. And there's this big effort called Operation Warp Speed. And I'll admit to this group, I'm the last person to ever support Trump, but I have to say the Warp Speed has been a pretty good program. They are moving all the resources of the federal government to shrink that timeline for vaccine development. And this is Francis Collins, who's the head of the NIH. And so their goal is to get a fast vaccine. So we're very proud here at Pittsburgh that we're part of a COVID-19 prevention network. This is funded by the NIH, and they're using our own infectious disease experts that normally work on HIV, but they're using them to run the vaccine clinical trial. And these are all the sites that are running the trial right now, and one of them is Pittsburgh here. And we're running this both at Children's Hospital and in Oakland at the Falk Clinic. So this is led by Judy Martin over at Children's and Dr. McMahon over at Falk Clinic, and they're leading this effort. And they're starting with 2 vaccines, the Moderna RNA vaccine, which has already started. 3 weeks ago, people got vaccinated. And then we have this AstraZeneca the Oxford vaccine. You probably heard about the Oxford vaccine. That's a vector one with that little adeno fake virus. And that, I think, starts in a week or two. And let me tell you quickly about this Moderna vaccine. They've already published the phase 1 safety studies in the New England Journal of Medicine. So they gave normal volunteers, and these are the side effects with the first dose and the second dose. And what you'll notice is people get a little bit of, this shows percentage, you know, so 30% would be about here. So about 30% of people get fatigue, about 5% get chills, about 30% get headaches, about 5% get muscle aches. Almost everybody gets some local symptom like their shoulder hurts. And almost everybody gets some pain from this vaccine. And it's a little more with the booster. So that was in normal volunteers. And these are antibody levels that form. And I'll just tell you that all of these levels are the formation of antibodies. And everybody at all 3 doses of the vaccine got very high antibody levels. And by the way, right here at the end, this is the natural antibodies that form in someone who actually had COVID-19. So they're focusing on this middle dose now for this Moderna vaccine, and they have started a 30,000 patient trial. It's enrolling now. Now, by the way, they want more African Americans and Latinos in this study. It turns out that a lot of people are signing up. They're getting tons of people signing up for the vaccine, but they want more Latinos and more African Americans because they need more underrepresented minority volunteers in this study. So they're not actually accepting people with sickle cell in the study now because of the functional asplenia. But if you're a family member, if you're African American, if you're a Latino, you know, let Andrea know, let me know, and we can get you in this study. The second, so this is the study that I mentioned. The second one, and then I'm almost done, is the what's called the Oxford vaccine. And this fake virus has been used in 14 previous clinical trials for diseases like influenza, tuberculosis, malaria. So the backbone technology has been used before for other viruses, and it seems to really work. And so this is they just published in a medical journal called Lancet their phase 1 results. What I like about this is they treated 1,000 normal healthy people aged 18 to 55, and they gave them this vaccine, which is this adenovirus with the RNA that makes the spike protein, and it was very well tolerated. And this shows the percentage of people that have a symptom. And this is the first dose and the second dose. And it looked like there was a lot less symptoms than the Moderna vaccine. So about 20 to 40% of people had some pain in the arm where they were injected, and tenderness and warmth. But you can see there wasn't much else. And it was even less with the second vaccine. And everybody was mild to moderate. And very similar to the Moderna vaccine, this is with the virus, and this is the second dose. You can see they got really good antibody levels 14 to 20 days after the vaccine. And this shows you the normal antibody levels in someone who had a real COVID-19 infection. So they've launched their big trial. They're going to enroll 30,000 people, and this is starting for people over 18. And again, they're very interested in getting people to enroll in this who are African American and Latino, because they have a lot of people who are Caucasian signing up, but we need people that are at higher risk. And for this study, it's a 2-to-1 randomization, meaning 2 people will get the real vaccine and 1 person will get a placebo. So it's 2-to-1 chance you'll get the real vaccine. And there's a lot of efforts to collaborate with the community, which I was talking to Andrea about, and I introduced Andrea to the PIs of this study, and I introduced Michael to the PIs of this study. And if you're interested, you can go to this site to register, or you can just email Michael and Andrea, and they can forward to me, and I can introduce you to the right folks. but they're enrolling for both vaccine trials now. So I will stop sharing, but just emphasize to everybody that all the safety steps, and please spread the word. We've got to fight this disinformation that we're hearing from these anti-vax people. Vaccines are the best way to prevent a disease. You know, vaccines have transformed civilization. You know, we all are safer because of flu shots and measles and mumps and rubella and tetanus and all these terrible diseases we don't get. And this vaccine, they're doing all the steps. It's just faster. You saw that they've already done safety trials in 1,000 normal volunteers in that Oxford J&J vaccine. And now they're doing 30,000 people studies. So I'm very confident that this is all the safety steps are in place. And it looks like it's a very promising immune response. So I'll stop there.
Well, thank you, Dr. Gladwin. That was amazing. And thank you all for staying on. I know we're past the hour, but we have just a few questions if you guys wouldn't mind staying on. And thank you, Dr. Bogan, for agreeing to staying on. I still see Dr. DeCastro here. So the first question after those amazing presentations is, was hydrochloroquine, is this drug given to sickle cell patients? And if so, why? The hydrochloroquine, that one that was in the news a little bit.
I can answer that if you want, or Dr. DeCastro. Well, we'll both answer, but there's no data, good data, that hydroxychloroquine works for SARS-CoV-2. It does work for arthritis, like rheumatoid arthritis, lupus arthritis, but the clinical trials that came out, people thought it worked, and they were using it early on in the pandemic in that first phase, but now all the studies have shown that it doesn't work. And we do not use it. In fact, in Pittsburgh, we never really embraced it. We didn't use it very much, but now nobody uses it anymore because the clinical trials were negative. Dr. DeCastro, do you want to add to that?
Yeah, I'm on mute now. Yes, remember that this registry is from data collected from March to now. So initially, some patients may have been treated with hydrochloroquine because at that time, the drug was believed to work or was being used in that. But I agree with Dr. Gladwin, it's not, it hasn't not found to be used or that have any benefit for COVID-19. We do have, in fact, that I know a couple of patients on hydrochloroquine because of the other indications, and they have been doing fine. But this is closely monitored by the rheumatology doctors regarding that. But I will not use it for COVID-19 based on the data available.
Okay. Well, thank you so much. Our next question is, I guess this is directed to Dr. Bogan. Is the flu vaccine available from the health department? Is that free, and what location?
So I think Hannah Hardy already put into the chat our immunization clinic update. We haven't started giving it yet, but it is free. And yep, so the immunization data from our clinic is there. It's located downtown in the Hartley Rose building. So convenient to sort of bus stops downtown. And again, if you are a patient in the sickle cell clinic, my guess is that they would also happily give it at the same time. So one of the disadvantages of coming to a clinic like ours is you're not also getting your health care. So I always tell people, if you have a primary care provider, we prefer you go there so they can check you out, make sure you're healthy, refill your medications, and do all the other things you get from a primary care provider or a clinic like a sickle cell clinic that you don't get at the health department. But if you can't, or it's not convenient and you want it from the health department, it's free and available.
Okay, thank you.
I am a healthcare provider by training, and I did, so I always wanted my own patients to come in and see me and make sure they were okay and see how they're doing. So I don't want to take that away from primary care doctors.
Okay, thank you so much. The third question is the isolation letter a legal document that can be used for work as a doctor's excuse?
I don't know exactly how to answer that. It is a letter that states that you need to stay home and be not at work, to be isolated from the date of the letter has dates of when it starts and ends for each person. So I assume most employers would accept that as a work excuse, but I don't know every work employer's rules of what they need.
Okay. the next question is, would you recommend people with sickle cell get the COVID-19 vaccination right away, or wait until some people have gotten it and it has not caused any adverse effects? That would be to Dr. Gladwin.
He's muted.
I'm not muting you, I promise.
No, it says I'm muted by you.
Oh, okay. Sorry about that.
Can you hear me?
Yes, you're
Okay,
yep,
good.
you're muted. Sorry about that.
Yeah, all right. So I don't know why it keeps saying I'm muted by the host. So I actually looked into whether we could make this vaccine trial available to our patients with sickle cell disease, and they said no. For the first round of this phase 2, they are not enrolling sickle cell patients because of the functional asplenia. So I think for the J&J vaccine right now, if you have sickle cell, at least that's what Dr. Ridler told me, that you can't be in that study. So you are going to have more information on safety before you have to make that decision. I think that if you don't have sickle cell disease, like if you're a mother, a father, or a sibling, or me, I think that there's plenty of data with that J&J with 1,000 people that it's very safe. And I think we have plenty of data that getting COVID-19 is not safe. So I feel very comfortable that going in the vaccine trial, if you don't have sickle cell right now, is very reasonable. Now, once the vaccine shows that it's efficacious, and I had sickle cell, I personally would strongly recommend getting the vaccine. Now, why do I say that? Because this is a very serious infection if you have sickle cell disease, as Dr. DeCastro showed you. We know that influenza and SARS-CoV-2, COVID-19, are very severe in patients with sickle cell. The risk of getting it is going to be very high this fall. The risk for, if you have sickle cell, of having a severe, infection is very high. So to me, when you look at the risk versus benefits, it really would favor getting the vaccine. So I personally would very strongly recommend that as soon as you know it works and it's safe from this big 30,000 person trial, that you try to get the vaccine. That would be my advice. Let me see what Dr. DeCastro says about that.
Yeah, I completely agree again. I think that once at this point that it's on clinical trials, I think we need larger information for a larger group of individuals. But once it has gone through the last stage of evaluation of safety and effectiveness, I will definitely recommend to get both the flu and the COVID vaccine as soon as available.
I mean, if you think about it, the greatest risk is it does cause pain when you get the injection, and it activates your immune system. And when you have sickle cell, as you all know better than I do, sometimes a minor thing can set off a crisis, right? The cold weather, having a headache, hurting yourself. There's small things that can set off a crisis. So it is possible that if you got the vaccine and you had a really strong fever response, some vaccines cause fevers and achiness while your immune system goes, it could trigger a crisis. But the vaccine is only that M spike. It's not the virus itself. So you would never get the virus invading your lung. You would never get the pneumonia that we see with COVID-19. So to me, the greatest risk for you would be that it might trigger a regular crisis, but it would not cause the pneumonia that we see in people with the real infection. So yes, I would recommend that you get both the flu shot as soon as you can. I would try to get the flu shot in the next month, and then I would try to get the vaccine once it works and it's been approved. And by the way, I do want to comment that if you do get sick and you come to the hospital with COVID-19, our patients are doing much better than they were before now. We're giving steroids, which have been proven to work. If you need oxygen, like you're getting the COVID-19 pneumonia, the steroids work. We're also giving remdesivir, which is an antiviral medicine that's now been proven to work. And so everybody's getting steroids, remdesivir. Some people are getting convalescent plasma, which is the plasma from someone that had COVID-19 that has antibodies. And we're seeing much lower severity of our hospitalized patients. So our outcomes are looking a lot better than they were during the first phase. And if you have sickle cell disease and you were to come in and have COVID-19, we would also be talking about giving you a blood transfusion to prevent chest syndrome. So we're being really aggressive with your treatment, and we're seeing really good outcomes.
Thank you so much. Well, everyone, thank you so much. This has been amazing. That was the end of our question and answers right now. But if you do have any further questions, you can email them in. And I'm going to put into the chat box where you can email them into support@CSCF Kids. And we will get the answers from our experts. And we will make sure that we get answers and get them right back out to you. We want to say happy Sickle Cell Awareness Month. We want to make sure that you guys are all living well with sickle cell. Can we put our cameras on? Does everyone who has a camera can put your cameras on so that we can get a little group shot here and take a picture? And
Andrea,
yes.
I have a question for Michael.
Oh, sure.
I want to know about that little bar behind him.
Yeah.
That looks pretty good. Is that the COVID emergency response system?
Exactly what it is.
Okay. Well, I'm gonna take this picture of everyone who's on here, and we're gonna say living well with sickle cell. Can we say that?
Yeah.
Living well with sickle cell.
With sickle cell.
There you go. All right. Well, thank you so much to our speakers. You guys have been amazing. We are so happy to have this partnership with the Allegheny County Health Department. All of you guys, you know I love you. Just stay well, stay safe, wear your mask, distance, and I hope to see you soon at one of our functions whenever this all is over. Thank you, docs, for all the things that you guys do all year long to keep us safe and healthy. Bye-bye.
Bye.
Bye.